Hey everybody, welcome to my Facebook Live. This is Dr. Shaunak Patel from the Patel Center for Functional Regeneration. Hope you guys are having a great Friday. Today I wanted to talk about a condition called spondylolisthesis. Spondylolisthesis is a fancy term that means that there's been a slippage of the vertebral body. This is something that actually is relatively common that occurs, and that's why I wanted to take the time to talk about this today. In past sessions, we've talked about disc degeneration, we've talked about disc bulging, we've talked about arthritis in the spine, and we've talked about how these things can cause irritation or pain in various different distributions, such as things like pain in the back, as well as pain going down the leg, in the butt, all of those type of stuff. But when we talk about things that cause pain, one thing that occurs that you might read about if you look at your MRI report or your X-ray report is this phenomenon called spondylolisthesis. So spondylolisthesis actually comes in various different varieties, and there are different causes for it. But first and foremost, we have to take a step back and say, what is it entirely, right? So I have this MRI here of a lumbar spine that I'm going to go into more in depth in a minute. But first, I'm just going to describe a little bit about the anatomy of the spine again. I know I've done so in the past with everybody, so I'm just going to draw a little bit so we understand. When we're looking at the spine from the side, the spine is like a stack of bones on top of each other, right? And this is the front of the body, this is the back of the body, right? And we have these kind of spikes, which are the spikes that we feel when we press the back of our spine. And the central canal here is what contains the nerves, and the nerves exit out of these space that's formed between the disc in the back and the joints between the vertebral bodies, in between each of the segments there. And the nerves exit and kind of go down the legs in different distributions. But what I want to point out here is that these stacked bones are on top of each other with the disc in between here, and then in the back we have ligaments that are connecting all of these bones together. Okay. And the ligaments, as I've mentioned in the past, those ligaments are like duct tape connecting bones together, or what I like to say are they're like those thick rubber bands that surround broccoli in the grocery store, right? There's a little bit of stretch to them. So this is important because not only do we have the disc, we have the facet joints in the back of the spine, and then we have the ligaments connecting all of these bones together. There's ligaments in the front of the spine here, bordering the front of the discs. There's ligaments in the back of these vertebral bodies, bordering the back of the discs. There's ligaments on the back of the spinal canal connecting the vertebral bodies together as well, connecting the spinous processes together as well. All of these are supportive structures, right? And this is going to come into play when we talk a little bit more about spondylolisthesis. Now, as we mentioned in the past, as we get older, these discs right here really start to get dehydrated, right? There's less fluid in them. And whereas before, when we're young, they're like water balloons completely filled with jelly, so they're nice and cushiony. As there's less fluid in those water balloons, they start to get a little bit more wobbly. And ultimately, that means that there's more motion that takes place between these vertebral bodies. Okay? As there's motion that takes place there, a few different things occur. Number one, these ligaments start to get a little stretched. So all of these ligaments that are connecting the bones together, they start to get stretched when there's more and more motion between these segments. as those ligaments get stretched, so imagine taking one of those thick rubber bands and gradually over time just stretching it, stretching it, stretching it, stretching it, what's going to happen, those rubber bands are going to get looser. So as those rubber bands get looser, that allows for more motion to take place between the vertebral bodies, right? Between these two vertebral bodies, there ends up being more motion that takes place, not only because the disc is getting more wobbly, but also because these ligaments are starting to get stretched. Now finally, these facet joints that are there, you know, the facet joints are interesting because the orientation of the facet joints allow for motion, but also allow for stability. As there's gradual motion that's taking place in between the vertebral bodies, right? So here's a model of the spine here. Let's see if I can align this correctly. Front of the body, back of the body, just like my drawing here. The squares are the vertebral bodies, the bones. This is the disc. And in the back here, we have the facet joints, which are where one bone meets another bone, right? Where one bone meets another bone. And as there's motion that takes place, as the vertebral bodies are moving, those joints are going to start to move. As there's friction on those facet joints, you know, we think about bones like these models, like they're not going to be, they're static, right? They're made out of plastic or whatever this is made out of. But in reality, our bones are living, breathing things. And as there's pressure on those joints, as there's friction that takes place there, the bone's like, hey, there's a lot of friction here. I have to change in order to accommodate that extra pressure, friction, force that's being placed on it. So the bone cells actually start to change. And what happens is the orientation of those facet joints start to actually change in order to allow for that extra motion to take place initially. So as the orientation of those facet joints change, that can allow for more motion to take place in between the segments of the vertebral body. So then all of a sudden what occurs then is that we end up with some changes that take place because instead of those vertebral bodies being stacked so clearly on top of each other, we actually end up having some motion between those vertebral bodies. So those vertebral bodies will either then move forward compared to the one above and below it, or move backwards in comparison to the one above and below it. And that is called spondylolisthesis. Okay. Now, that in itself does not necessarily mean anything. What we need to then know is what level of spondylolisthesis is occurring and what is that spondylolisthesis actually causing. And I'll get into that in a second. So the way that I describe this right now really is what one type of spondylolisthesis. Spondylolisthesis, or slippage of the vertebral bodies, that is, there's a few different varieties of that can take place, and one of those varieties is degenerative by nature. The other variety that takes place there, there's other varieties, plural, that take place, one of which it involves actually breaking of some of the bones that connect to the facet joints. This is called spondylolysis with breakage, and that could actually be a result of a degenerative process as well, or it could involve, it could occur when we have a traumatic fracture. This is something that we can see with even young people and athletes, for example, when you're involved with a sport that involves a lot of bending backwards, a lot of bending and twisting. You know, we see this in tennis players, volleyball players, people that are bending backwards and twisting and causing there to be some excess torque and pressure onto the back of the spine. That can cause what's called a pars defect. I recently saw a patient that was involved with shot put and other kind of forceful twisting type maneuvers. These are the type of things that can cause an injury or a fracture to the part of the bone called the pars interarticularis. And that pars defect or pars fracture that occurs then further allows for there to be motion between the vertebral bodies. Further allows for that spondylolisthesis to occur. There are other types of spondylolisthesis, things that are associated with, things like cancer and other reasons to cause that slippage to occur. A significant trauma, such as a car accident, could also predispose to a situation such as this. But I'm going to focus primarily on the degenerative aspect as well as that's associated with those pars defects, whether or not that's traumatic or degenerative in nature. So when we talk about this, what are the different stages or severities of spondylolisthesis? So when we talk about spondylolisthesis, there are different stages of how we can say it is or is not severe. So going back to drawing our little vertebral bodies here, let's see. Oops. Technical difficulties here. Oh, here we go. When we draw these vertebral bodies, if we think of this as being a completely normal level with no spondylolisthesis, again, this is the front of the body, right? Grade 1 means that there's been slippage of one vertebral body on the other by 0 to 25%. So if we were to think of that 0 to 25%, what does that exactly mean? That means 0 to 25% of the length of the vertebral body. So if we split that into fourths, right? If we had slippage of one vertebral body forward, um, 0 to 25% of the distance of the vertebral body, that's called a grade 1 spondylolisthesis. Okay. Grade 2 means that the vertebral body has slipped 25 to 50%. Okay. So 25 to 50% slippage of the vertebral body is grade 2. Grade 3, actually let's see if I can there we go. Grade 3 is 50 to 75%. Right. Starting to get a little scary. Grade 4 is 75 to 100%. And grade 5 is actually over 100% slippage, and that is something that is associated with major traumas. Now, most of the time when people are sitting at that spondylolisthesis diagnosis that has been given to them, their MRI reports or something along those lines, most of the time people fall into that grade 1 or grade 2 category. Now, when we think about this and how scary this sounds, typically when we talk about grade 3 and above, that's a situation that absolutely requires surgery. So grade 3, grade 4, grade 5 absolutely requires surgery. Now, for grade 1 and grade 2, surgery may or may not be necessary. In fact, more often than not, grade 1 or grade 0, surgery can be avoided without any issues whatsoever. Grade 2 falls into that category, that if there is substantial instability that's taking place, and if there are substantial neurological deficits that are taking place, a grade 2 spondylolisthesis is a situation that surgery may be the most reasonable option. What does surgery involve with situations like this? Well, surgery involves, in more often than not, would involve something like a fusion, where the position of these vertebral bodies needs to be corrected somewhat, and then hardware needs to be placed in order to keep those vertebral bodies in a good position. Okay, but grade 1, grade 0, and even most grade 2, we can oftentimes avoid surgery. So what are the different symptoms that patients with spondylolisthesis present with, and what can be done about it? What can be done about it non-surgically? And let me talk a little bit about also what instability means on a macroscopic and a microscopic level. So when we talk about instability, what does that mean? There are times where you'll see that a spine looks like it has a little bit of a grade 1 spondylolisthesis, of the vertebral bodies, where it's slipped less than 25%, right? But when you look at the body in flexion or bending forward, that slippage actually increases, right? When you bend forward, that slippage increases. That is a sign of instability. If that slippage increases by a matter of a millimeter or two, then it may not be the end of the world. But if that slippage increases from a grade 1 to a grade 2, or a grade 2 to a grade 3, this is a sign that those vertebral bodies are not staying stable. There's too much motion going on, and that might be causing an increased risk of damage to the nerves that travel right past these discs and go down the legs. Now, if those nerves are being impinged because of that instability, then it's a situation where every time you're bending forward, when that slippage increases, that can cause increased pressure onto the nerves and cause damage to be occurring. In some situations, bending backwards may cause that instability to occur. So when we have a spondylolisthesis like this that we're suspecting might be involved in a condition, in order to figure out is there some instability issue that's associated with it, we oftentimes get x-rays done in flexion and in extension, meaning not only just in the neutral position, straight up and down, but also with bending forward and bending backwards, flexion and extension. And by doing that, we can see, all right, is there some motion that's actually taking place at these segments or not? There are also MRIs that could be done in flexion and extension to see what the disc looks like, what the nerves look like. Is there actually some impingement going on in that flexion and extension? That could also be very, very valuable to the treating physician. Because if there is substantial instability, that's something that we need to think about and realize that if there is nerve damage that's occurring due to that, then that might be a situation where surgery is absolutely necessary. Now, if there's only a tiny bit of instability that's there, or if it's instability going from a grade 0 to a grade 1, right, and there's not substantial nerve damage associated with this, then this is a situation where you have, instead of macro instability or gross instability going that's more concerning, this might be a situation of what we deem as micro instability. And what does micro instability mean? Well, ultimately that means that the ligaments that are connecting these bones together are getting excessively stretched, and the stretchiness or the looseness of the ligaments is contributing to that small movement that's taking place. And as there's more and more motion that's taking place, that can cause more arthritis to occur, that can cause irritation to the nerves, that can cause irritation to the discs, etc., etc. So microinstability is a situation where we may actually be able to help by trying to strengthen the ligament structures. And I'll get into what that looks like in a minute. So what does this look like on imaging, right? What does this look like on an X-ray? What does this look like on an MRI? So this is an X-ray. This is a side view X-ray of the lumbar spine down at the area of the sacrum. If you look here at these different segments, I'm just going to outline with the vertebral bodies here. Right here is the vertebral body. This is going into where the facet joint is, and this is the spinous process. Okay, this is the facet of the lower vertebral body here. This is L5. And can't really see the spinous process there, but trust me, it's there. And this is where the disc would be right here. When we look at this segment below it, though, you can see that the S1, or the sacrum, is actually like so. Actually, I don't even say it's further out than that, but that is some forward slippage of the vertebral body, essentially, comparison to the sacrum below it. Yeah, let's do something like that, right? So you can see how that disc level here is most likely sheared or stretched, and that causes some narrowing of where the nerve would be traveling right there. Okay? So if you could picture that, that is what, in this instance, looks like a borderline grade 2 spondylolisthesis, because when we look at how far the vertebral body has traveled, we look at this being, actually this is, grade 2, right? That's 50%, that's 25% here. So this has traveled about 25% forward in comparison to the vertebral body above it, and that's why we would call this a grade 2 spondylolisthesis. I'm going to show you another picture of this same patient. This is that patient's MRI. And in this picture, you can clearly see that there is a slippage of the vertebral bodies. Again, when we're looking at these levels here, these squares are the vertebral bodies, the bones. This is the central canal where the nerves are traveling. Right? This is the spinous process in the back. We don't see the facet joints because this is a cross section right in the middle of the spine. So the facet joints are on either side of this particular image. We can see the disc in between these vertebral bodies. And for all intents and purposes, these segments up here are perfectly normal. This black line that we see on the front of the vertebral body is a ligament. This black line that we see on the back of the vertebral body is a ligament. Black lines here are ligaments. Black in between here are all ligaments. All of these connecting bones together. Now when we go down to this segment here, we could see this vertebral body is now forward in comparison to the vertebral body below it. Okay, it is forward, and if you measure, again, that being about 50%, that being about 25%, we're somewhere in between the 25 and 50% mark, so that is a grade 2 spondylolisthesis of these two segments here. Now, what we don't see is kind of a side view of where the nerves are traveling, but there is narrowing of where the nerves are traveling at that level. And this particular patient, even though there was narrowing of where the nerves were traveling on both sides, she only had symptoms going down the left leg all the way down to her heel. And that was contributing to a knee condition that she had. She had knee arthritis and a previous arthroscopic surgery. And she actually had some worsening of her knee symptoms because of the nerve irritation in the low back, which was causing her to walk abnormally. Um, Now, the reason that she had this spondylolisthesis was over time there was some arthritis that was taking place, and then we are not quite certain if this was associated with a trauma, but she ended up with pars fractures on both sides of her spine, and that is what has led to that slippage of those vertebral bodies. So this patient came to me and said, hey, I have some knee pain, I have pain, tingling, burning going down the left leg. What can I do about it? We did flexion extension x-rays, and we saw that the vertebral body stayed pretty stable at that grade 2 spondylolisthesis. I did a physical exam on her, and she had a little bit of weakness, but not some gross, significant weakness. So we wanted to try to avoid surgery, so we decided to do a combination of treatments to try to help the low back. The treatments that we decided to do included physical therapy and exercise, and we did an orthobiologic treatment using this patient's own blood growth factors, and I injected those growth factors into the epidural space. I injected those growth factors along the nerves here, along the discs and along the ligaments here, in this area where the ligaments are, as well as the ligaments throughout this region that are connecting all of these bones together, with an attempt to get those growth factors to strengthen those ligaments to take pressure off of the nerves. The platelet-rich plasma, or PRP, that I injected into the epidural space, so that's the space that surrounds these nerves, we use that to help calm down the inflammation surrounding the nerves. And ultimately, we wanted to get her left-sided nerves to act like her right-sided nerves, right? Because there was narrowing of where the right-sided nerves were too, but she had no symptoms on the right. So by doing a combination of these treatments, we were able to decrease all of the pain going down her left leg, and she was left with a little bit of burning on the bottom of her foot. And that burning on the bottom of the foot, quite frankly, may have been due to her low back, or may have been due to a previous injury that she had in her foot itself. And at this juncture, we're a couple years out from her procedure, and although she still intermittently has some knee pain, which we also treated, and we're due for a new treatment, the pain from her low back and the nerve irritation from the spondylolisthesis, that pain, for all intents and purposes, is still decreased at this point, and we've been able to avoid surgery. In situations like this, some patients may opt for surgery, but this patient particularly did not want to do surgery, and we wanted to treat it conservatively, and we actually were able to get great benefits. And I have to say that I stay in contact with this patient on a very regular basis, because this patient is my mom. And when she comes back and visits, it's been over a year since she's visited due to COVID, but once she's coming back to visit in another month or so, she got her vaccines and all that, you better believe I'm going to be treating her back again to make sure things stay stable with that spondylolisthesis. So the point of this story was that spondylolisthesis is something that occurs due to degenerative reasons. It can occur due to fractures or trauma, and spondylolisthesis comes in a few different flavors in terms of the cause, as well as a few different stages depending on the severity. If you're a stage 1 or stage 2 spondylolisthesis, which is 0 to 25% or 25 to 50% slippage, oftentimes surgery is able to be avoided as long as we're not significantly unstable in the area. If you're grade 3 or above, that's the type of situation that surgery is absolutely necessary. But if you are grade 2 or grade 1 or with micro instability and not macro instability, then we can oftentimes treat this type of condition with a combination with appropriate physical therapy and strengthening, as well as using a patient's own orthobiologics such as PRP, bone marrow, etc., to help with strengthening the soft tissue structures around this slippage. I hope this all made sense. I'm going to go to the comments quickly to answer some questions here. Kathy says hi. She said happy early National Doctor Day. Thank you so much, Kathy, and thank you always for your support. I really appreciate it. Eric said, I had spondylolisthesis back in the 70s and 80s and had a spinal fusion done from L4 to S1, S1 to L4. Yeah, you know, sometimes the spondylolisthesis is absolutely necessary to have a fusion, and you know that can be a game changer, right? That could take pressure off of nerves that are being damaged, and it can be absolutely necessary. Unfortunately, fusion surgery does have a lot of side effects associated with it. You know, as if the fusion goes 100% correctly, barring any potential adverse effects associated with it, when you fuse two segments together, you run the risk of causing what's called adjacent segment disease, in which there's more irritation above or below the fusion that takes place. And even patients can develop spondylolisthesis above or below fusion sites when there's more motion that has to take place to make up for the lack of motion at the fusion site. But in reality, fusion surgery is still sometimes absolutely necessary. But after that type of surgery, we need to do certain things in order to try to prevent you know, adjacent segment disease from taking place. So doing diligent physical therapy and exercise afterwards could be really, really important. And doing things like orthobiologic injections to strengthen the soft tissue above and below the area, or to calm down any associated nerve irritation or arthritis type symptoms above and below the fusion could be very, very important. You know, trying to think of it not so much as a reactive medicine, but thinking of proactively, there are things that we can do to prevent things from getting worse. Final little tidbit that I want to talk about is the fact that you know, I've been seeing a lot of patients with hypermobility. You know, I see a lot of athletes. We see this particularly with young female athletes, but really we see this with all ages, and patients have various different types of hypermobility. You may remember kids, you know, a friend of yours or yourself maybe, that was double jointed with various different joints. That double jointedness involves looseness of your ligaments. That's oftentimes a genetic thing. This could be caused, not genetically, but it could be caused by what's called over-manipulation syndrome. When you have too much manual therapy, like chiropractic adjustments or some osteopathic treatments that cause too much stretching of the ligaments, can cause a hypermobility in one way, shape, or form. But there are folks that are just born with it. Why does this play a factor into spondylolisthesis? Well, the ligaments are what hold all of the spinal segments together. And if we naturally have a little bit of stretchiness to those ligaments, if we naturally have a little bit looser rubber bands holding all of these things together, then we have the possible inclination or possible predisposition towards that slippage occurring. So if you do have if you do have hypermobility, if you know that you've had that, whether you've diagnosed with that or you think that you have it because you're double jointed, etc., and if you're starting to develop some low back pain, it's number one, be careful about doing any excessive manual therapies, cracking type maneuvers, because that could make your hypermobility worse. But also, if you're having this back pain that's low grade and it's just keep on poking its head, you might want to get that checked out with appropriate physical examination and imaging to make sure that we're not dealing with something like a spondylolisthesis that's gradually starting to occur. I hope all that made sense. You know, K.A. Rim says, I have a C1 to C7 instability, and prolotherapy really helped me. I'm still in the process, got the 4th treatment last week, feeling much better. You know, instability in the neck, this spondylolisthesis, although I've been focusing on the low back, the spondylolisthesis can occur in the neck as well. And whether it's, again, that macro instability of a true spondylolisthesis or even a little micro instability can be very common in the neck. And prolotherapy or sugar water injections to the ligament structures can actually be really, really beneficial. Thank you, K.A. Rim, for your comment, and I am wishing you the best of luck on your recovery. Well, thank you so much, everybody, for joining me. If you enjoyed this, if this was educational, if you found it helpful, then please like it, please share it. If you have any questions about your particular condition, or general questions at all, feel free to comment, DM, or you can email us at info@fxregencenter.com. Hope you guys have a great Friday, and wishing you a best weekend. That wasn't a statement that makes sense, but hey, have a good weekend. Stay tuned next week. I think we've covered a lot of low back topics at this point. I think maybe next week we'll talk about how to read an MRI of the spine, and then we'll move on to some other topics. So if you're interested in something specific, let me know and I'll integrate it into our future Facebook Lives. Wishing you all the best. Have a great weekend and see you next week.